Hello. In this segment, we'll be discussing about a major psychotic illness called as schizophrenia. So, schizophrenia is a major psychotic illness which is characterized by disturbance in thought, perception, emotion, motor behavior, and in relationship to external society. So, if you come to the brief history of schizophrenia, how it developed and all that, only in the 1896, Emil Kraepelin, he divided mental illness into two parts. One is a continuous illness called as dementia precox, which was later called as schizophrenia, and major depressive illness, which we call as manic depressive illness. Manic depressive MDP. It was called MDP. Now we call it as bipolar affective disorder. So MDP was something which comes and goes, and dementia precox was a continuous illness. Then Eugene Breuer in the year 1911 was a person who coined the term schizophrenia. So Eugene Breuer gave the name schizophrenia, and he gives the 4 A's. The symptoms of schizophrenia was 4 A's, which was ambivalence, which is confused between what to do or not to do, autism, withdrawal into self, affect disturbance, emotional disturbance, and associate disturbance, that is loosening of association or the thought disorders. So this was the 4 symptoms which was given for the clinical manifest for the diagnosis of schizophrenia. And later in the year 1959, Kurt Schneider gave the first rank symptoms, FRS. So there are 11 FRS. So first it starts off with hallucination, that is first person, second person, third person auditory hallucination. The next one is thought insertion, thought withdrawal, thought broadcast. The next is made will, made affect, made volition, and somatic passivity, and the last one is delusional perception. So these are the 11 clinical manifestation of or the first rank symptoms according to Kurt Schneider. Okay, so if you just see the terminologies, all these terms have been discussed and you will understand. Now coming to schizophrenia as such. So what is the epidemiology? So epidemiology is the prevalence at any given rate 0.5 to 1% of the population suffers from schizophrenia. You know the population of India, and imagine if 1% of population of India has to have schizophrenia, what is the amount of people we are having in the entire world suffering from schizophrenia? And the incident rate, every year we have about 0.5 per 1,000 population. Every 1,000 population 0.5. So all of us have about 0.5% of chances of developing schizophrenia. Now coming to the clinical manifestation, clinical features. So the clinical features are thought and speech disorder is the first one. So in thought and speech disorder, the first one is given as your autistic thinking. So they have a private and illogical way of thinking. Okay, so like here it is written like, Lord Rama is Hindu, I am a Hindu, so I am Lord Rama. So it's your own private and illogical way of thinking, and there will be loosening of association. You cannot understand what the patient is speaking. One sentence does not make any sense, and thought blocking. Suddenly the patient talks and stops and not able to remember what he was speaking before. Neologism, coining new words, and the patient will be having a speech disorder like a thought and speech disorder like perseveration, verbigeration, echolalia, okay, and mutism, poverty of speech, okay, poverty of ideation. All these things can be basically seen. So apart from it, the main thought disorder is your delusions. So in schizophrenia, mainly we see delusions. So you'd see delusions of persecution, reference, jealousy, grandiosity. So these are the delusions which you basically see. So the first symptom is thought and speech disorder. The second symptom is disorder of perception. So disorder of perception mainly auditory hallucination. We have first person auditory hallucination, thought echo, second person auditory hallucination, running commentary, third person auditory hallucination, two or more people talking about the patient as a third person. Now second and third person auditory hallucination is a clear-cut diagnosis of schizophrenia. And the person can also have visual hallucination, olfactory hallucination, gustatory, tactile hallucination can also be present. The next one is delusion of affect. So emotionally it is blunt. They do not have much of emotional experience, inability to experience any pleasure, anhedonia. Okay, so flattered, blunted affect is what is based, or inappropriate affect. Okay, so when something happy is happening, they cry, or when everybody is sad, they're laughing. Inappropriate affect. Then we also have things like patient will not have rapport, patient communication. Okay, patient will not initiate a conversation or maintain the conversation. The next symptom is disorder of motor behavior. So there can be increased motor behavior, or there can be reduction in the motor behavior. And the patient will also have catatonic features, which we will come to it later. Okay, catatonic stupor, or they can also have stereotyped behavior, mannerism, grimacing, looking at the mirror and smiling. So these things can also, mirror gazing, grimacing, can also be seen. The next symptom, which is the fifth symptom, is negative symptoms. Now delusion and hallucinations are called as positive symptoms. Delusion and hallucinations are positive symptoms. What are negative symptoms? Negative symptom is when the patient does not communicate with anybody, social isolation, withdrawn to self, okay, not interested in any activity, nothing makes the person happy. So these are all the negative symptoms, more difficult to treat. Okay, positive symptoms, the prognosis is good. Negative symptoms, the prognosis is poor. So everything starts with A. Okay, affective flattening, attention impairment, avolition, apathy, anhedonia, asociality, alogia. Okay, all these are the negative symptoms. What are the other features? Other symptoms are patient will be having multiple aches and pains. Okay, multiple body pains. They will be work production will come down. Okay, they will not be able to work so efficiently. Okay, insight is poor. These are some of the other symptoms. And the seventh symptom is suicide. Okay, there is suicide in schizophrenia. Next to depression. Okay, so the highest number of death in psychiatry is because of depression. The second leading cause of death in psychiatry, patients with psychiatric disorder, is schizophrenia. Why? Because of command hallucination. So when they get the hallucination which keeps telling them, jump, kill yourself. People are trying to harm you. They're going to kill you. Kill yourself. So they will commit suicide because of command hallucination, listening to the voice. They react to the voice which they listen to. So these are the 7 clinical manifestations: thought and speech disorder, disorder of perception, disorder of affect, disorder of motor behavior, negative symptoms, other symptoms, and the last one was suicide. Now, ICD-10 diagnostic criteria. If you just have time, just go through it. You needn't have to by heart these ICD-10 diagnostic criteria. Now, coming to the next part, which is the subtypes, the clinical types of schizophrenia. So mainly we classify into 8. So the types are paranoid schizophrenia, hebephrenic schizophrenia, catatonic schizophrenia, residual schizophrenia, undifferentiated schizophrenia, simple schizophrenia, post-schizophrenia, depression, and others. So the first 3 are paranoid, hebephrenic, and catatonic are the main 3 types. So if they do not belong to any of these, they are put into the rest of the category. Paranoid, hebephrenic, catatonic, residual, undifferentiated, simple, post-schizophrenic, depression, and others. Now we'll just briefly go through each type of these schizophrenia. So what is paranoid schizophrenia? So paranoia means suspicious. Okay. If you remember the Shakespeare's um, play, okay, Othello and Desdemona. Othello starts suspecting his wife and he murders his wife. Okay, that is paranoia, suspiciousness. Okay, so in paranoid schizophrenia, you mainly see the person with main feature is delusion and hallucination, and of course disturbance in the volition, speech and things like that. No disturbance in their affect speech. So the main thing is delusion and hallucination are the main two clinical features. So what are the delusion? Delusion of persecution, people are trying to harm me, kill me. Delusion of grandeur, I'm great, I'm something very important, exaggerated self-importance. And delusion of infidelity, my partner is not faithful to me. Delusion of control, thought insertion, thought withdrawal, thought broadcast. So these are the delusion which is seen. And of course you see hallucination, it's you most predominantly it is persecutory type of auditory hallucination. It can be grandiose also. Some of the beggars you must have seen on the road, they'll be just talking to themselves, busy, like some imagine they'll be just talking to some, walk to themselves and walking on this. So these are the people who start living with these auditory hallucinations. So if you have time, watch this movie called A Beautiful Mind. It's a beautiful movie where Nobel Prize winner, what he experienced in life with auditory and visual hallucination and how he overcomes it. Okay, A Beautiful Mind. Okay, fine. So mainly that's no disturbance in their speech, other motor activity, there's no disturbance. Mainly it is delusion and hallucination. Now this starts off in by the time the person is in the late 20s. Okay, by the time you're 30, you start having the symptoms, and it's very gradual. Okay, it's insidious, we say, very gradual onset. And if the prognosis is the condition deteriorates very slowly, okay, over a period of time. I have seen people even for 30 years they have almost sustained their activity to a good level for 30 years or so. Doctors, professors, with this only slight impairment can be there, they can almost continue with their normal routine if they are under proper treatment therapy. Okay, so that is about paranoid schizophrenia. Okay, starts off with your third or the fourth decade. The next one is hebephrenic. Hebephrenic or disorganized schizophrenia is a worst type of schizophrenia with a very poor prognosis. It starts off among teenagers. Okay, so mainly it is it's characterized by thought disorders. Okay, and like loosening of association. Now in here the hallucinations and delusions are there, but they keep changing. Okay, in paranoid schizophrenia they're very strong. Okay, so they retain the same content for a long period of time, similar type of hallucination. But in disorganized or hebephrenic, it says fragmented and fleeting, it keeps changing. Okay, and mainly they present with emotional disturbance in the form of blunted affect, senseless giggling, you'll be seeing them like some of the teenage girls, and mirror gazing, always looking into the mirror, smiling at the mirror. Okay, for a long period of time they keep looking at their behavior, disinhibited behavior, and poor self-care, poor personal hygiene. They stop communicating much with others. Performance of occupation comes down, extreme social withdrawal, odd behavior. All this is basically seen. Okay, and again it starts off by teens, second decade it basically starts, and it is it is progressive and downhill. The prognosis is very poor, they deteriorate. Okay, the patients deteriorate, and severe deterioration is also seen, and prognosis is the worst type of prognosis is for hebephrenic schizophrenia. The third type of schizophrenia is called as catatonic schizophrenia. So catatonic schizophrenia is mainly with your mobility, body motor activity. So you have two types, which is catatonic excitement and catatonic stupor. So catatonic excitement is increased psychomotor activity without any non-goal directed. So you see suddenly patient becomes violent, starts beating, hitting things and destroying, and agitated, restless, aggressive, violent behavior, very difficult to control when the person goes into catatonic excitement, and increased speech, pressure of speech, loosening of association, all this can be seen. The next one is catatonic stupor or retarded catatonia. This is a common type which you will be basically seeing. So the patient will be like, when the patient comes to the hospital, they'll be just lying down on the bed, not talking, not doing anything. Sometimes they'll even void, they'll pass urine and stool, everything on bed. They'll not eat, they'll not interact, they'll be just looking somewhere, no movement. Okay, so we all the psychomotor activity, what symptoms, pathology which we have discussed, please go back to the clip where you'll see they'll have mutism, rigidity. Okay, so they maintain a rigid posture for a long time, negativism. So whatever you try to say, they just they'll not move or not obey to the whatever we say. Posturing, retaining a bizarre position and maintaining it for a long period of time. Stupor, okay, no movement. Echolalia, echopraxia, waxy flexibility, like wax you can mold their body, keep twisted hands and legs and keep them for a long time. Patient will retain like that for a very long time. Ambitendency, if you tell something like show your tongue, the person whether to do or not to do. Okay, and mannerisms, stereotypes, and all other symptoms which is seen in catatonic schizophrenia. Again, in the late 20s, it is seen, early to late 20s, you see this particular type of schizophrenia. These are the main three types of schizophrenia. Now coming to the other types of schizophrenia is residual or latent schizophrenia. So this is a person who has been having schizophrenia for past 1 year. After 1 year, now he comes predominantly with negative symptoms. Alogia, asocial behavior, apathy, anhedonia. Yeah. So those are the main negative symptoms. The person comes, and the person has been having schizophrenia before and for last 1 year, the delusion and hallucination may have reduced, but now the person comes with this, and there's no organic or there's no brain medical disorders is not there in these patients. The fourth one is called as undifferentiated schizophrenia. When you cannot put them in any of the other subtypes, we call it as undifferentiated schizophrenia, but still there are some of the characteristics which we see in schizophrenia. So that's why it's called as undifferentiated schizophrenia. The sixth one is a simple schizophrenia. Although it is called as simple schizophrenia, it is the most difficult type of schizophrenia to diagnose. Why? Because they come with mainly negative symptoms. It starts off with negative symptoms, withdrawn, no emotional response, vague body pains and aches. They, very shabby, wandering. So if you see like people are like beggars on the road, it's basically, homeless people on the road. It's this type of a thing which is simple schizophrenia. And the last one is called as post-schizophrenic depression. So the person would have had one episode of schizophrenia for 1 year he's been having, and now he comes with symptoms of depression, sadness, withdrawn, suicidal risk. All this can be there, but already the person is suffering from schizophrenia. So when schizophrenia and mood symptom come, that's a different schizotypal disorder, but we are talking about post-schizophrenic depression. Patient has schizophrenia, now he comes with depressive symptoms. And the other one is other types of schizophrenia. When they cannot be put in any of the subtypes, then they are put in other subtypes. Like we have this Van Gogh syndrome. Van Gogh was a very famous artist. You must have seen his paintings and all. When there were times when he was really creative, that's and dramatic. And there was Van Gogh syndrome is severe self mutilation, okay, self injury and self mutilation. So that's called as Van Gogh syndrome. And pseudoneurotic, one type of subtype which I want to talk to you all is about Crofts schizophrenia. PFROPF. All these are German terms, so it's quite difficult for us to pronounce. It's schizophrenia also to pronounce. It's not, it's not easy for us Indians. So it's Crofts schizophrenia. PFROPF. Crofts schizophrenia. So mental retardation with schizophrenia symptoms is called as Crofts schizophrenia. So these are the other subtypes. So what are the subtypes of schizophrenia? Paranoid, hebephrenic, catatonic, undifferentiated, then residual, simple, post-schizophrenic depression, and other subtypes. Okay, so these are the 8 types of schizophrenias which you have to basically remember. Okay, so the next segment we'll talk about the etiology and the etiology, prognosis, and management of schizophrenia.